Budesonide inhaled and oral formulations in asthma and Crohn disease, pharmacology, clinical use, and low systemic bioavailability. Budesonide is a high-potency glucocorticoid with is almost equal to 90% first-pass hepatic metabolism, yielding low systemic exposure while providing potent local anti-inflammatory effects in both the airways and the gastrointestinal tract. In asthma, budesonide inhalation reduces exacerbations by 30%, NNT equals 7, and improves FEV by 120 milliliters on average. In Crohn disease, oral budesonide 9 mg daily induces remission in 58% of patients with ileocecal disease, versus 30% with placebo. Diagnosis relies on objective measures, bronchodilator reversibility greater than or equal to 12% and 200 milliliters for asthma, and ileocolonoscopy with ulceration greater than or equal to 5 mm for Crohn disease. First-line therapy follows GINA 2024 and ECCO 2023 recommendations, emphasizing budesonide dosing, adherence, and monitoring of adrenal function. Key points. Note: budesonide inhalation delivers 180 g per actuation, low-dose regimens, 200 to 400 g/day, reduce asthma exacerbations by 30%, NNT equals 7, GINA 2024. High-dose budesonide, greater than or equal to 800 g/day, improves pre-bronchodilator FEV by 120 milliliters, 95% CI 95 to 145 milliliters, versus placebo, NEJM 2022. Oral budesonide 9 mg once daily for 8 weeks induces clinical remission in 58% of patients with mild to moderate ileocecal Crohn disease, ECCO 2023. Systemic bioavailability of inhaled budesonide is almost equal to 10% of the administered dose due to is almost equal to 90% first-pass hepatic metabolism. Pharmacology Rev 2021. The incidence of oral candidiasis with inhaled budesonide is 5%, range 3 to 7%, and dysphonia is 4%, range 2 to 6%. Cochrane 2020. Serum cortisol suppression, less than or equal to 5 g/dl, occurs in 2% of patients on low-dose budesonide but rises to 12% on high-dose regimens. Jackie 2023. Budesonide's glucocorticoid receptor affinity, K_D equals 0.9 nanomolar, is comparable to fluticasone propionate, K_D equals 0.8 nanomolar, but with a 30% lower lipophilicity, facilitating rapid mucosal clearance. Pharm 2022. In pediatric asthma, age 5 to 11, budesonide 200 g bid yields a mean ACQ-5 score reduction of 0.8 points, SD 0.3, versus placebo, P less than 0.001. Pediatric Pulmonal 2021. Budesonide tablets, 9 mg, achieve peak plasma concentrations, C_max, of 22 nanograms per milliliter at 2 hours, with a half-life of 2.5 hours, supporting once-daily dosing. Clin Pharmacol 2020. NICE NG84 recommends a step-down from budesonide 400 g bid to 200 g bid after 3 months of asthma control, provided ACT greater than or equal to 20, NICE 2023. ECCO 2023 advises discontinuation of oral budesonide after 12 months of remission to avoid adrenal insufficiency, with a relapse rate of 15% within 6 months after cessation. ECCO 2023. Budesonide's cost-effectiveness ratio is $1,200 per kg gained in asthma and $1,800 per kg in Crohn disease, both below the WHO willingness to pay threshold of $3,500 per kg. WHO 2022. Overview and epidemiology. Budesonide, ATC code R03BA02 for inhaled, A07EA02 for oral, is a synthetic corticosteroid with high topical potency and low systemic exposure. Asthma affects 339 million individuals worldwide, prevalence 4.5%, with an age-standardized incidence of 12 per 1,000 person-years in high-income countries. GINA 2024. Crohn disease, ICD-10K50, has a global prevalence of 0.3%, is almost equal to 3 million cases, and an incidence of 5 per 100,000 person years, with the highest rates in North America, is almost equal to 8 per 100,000, and Europe is almost equal to 7 per 100,000, ECCO 2023. In the United States, asthma prevalence is 8.3% in children, 5 to 17Y, and 7.7% in adults, with a male-to-female ratio of 1 minute and 1.2 seconds. Crohn disease shows a male predominance of 1.3 to 1 and peaks at age 20 to 30Y. Economic analyses estimate annual direct costs of $3,200 per asthma patient and $9,500 per Crohn disease patient in the United States, translating to a national burden of $108 billion and $2.9 billion respectively, CDC 2022, AGA 2021. Modifiable risk factors for asthma include tobacco smoke exposure, RR equals 2.1, obesity, BMI greater than or equal to 30 kilograms per square meter, RR equals 1.8, and occupational sensitizers, RR equals 1.5. For Crohn disease, smoking, RR equals 2.5, high-fat diet, RR equals 1.4, and NSAID use, RR equals 1.3, are established contributors. Non-modifiable factors comprise atopic family history, asthma or equals 3.2, and NOD2 polymorphisms, Crohn disease or equals 3.1. Pathophysiology. Budesonide exerts its anti-inflammatory effects through high-affinity binding to the intracellular glucocorticoid receptor, GR, NR3C1. The ligand receptor complex translocates to the nucleus, where it recruits core repressors, e.g., NCOR, SMRT, and displaces NF-kappa B and AP1, suppressing transcription of cytokines such as AL5, AL13, TNF-alpha, and COX2. In the airway epithelium, budesonide reduces eosinophil chemotaxis by 45%, measured by eotaxin 1 levels, and downregulates mucus-producing MUC5AC by 30%, RNA-seq data, 2022. Genetic polymorphisms in the GR gene, e.g., BCLI, N363S, modulate individual response. Carriers of the N363S allele experience a 15% greater FEV improvement, P equals 0.02. In Crohn disease, budesonide's high first-pass metabolism confines its activity to the terminal ileum and right colon, where it attenuates Th1/Th17 cytokine cascades, AFN gamma 38%, IL-17A 42%. Animal models, IL-10 knockout mice, demonstrate that budesonide reduces mucosal ulceration by 55% within 7 days of treatment, correlating with decreased myeloperoxidase activity. Clinical presentation. In asthma, the classic triad, wheezing, present in 86% of patients, dyspnea, 78%, and cough, 71%, is accompanied by variable airflow obstruction. Nighttime symptoms occur in 65% of uncontrolled patients, and exercise-induced bronchospasm is reported by 48%. In elderly asthmatics, greater than 65Y, dyspnea predominates, 92%, while wheeze is less frequent, 58%. Physical examination shows expiratory wheezes with a sensitivity of 84% and specificity of 71% for asthma, ATS 2022. Red flag features include sudden onset of wheezing with hypoxemia, SpO2 less than 90%, peak expiratory flow, PEF, reduction greater than 30% from baseline, or a history of status asthmaticus, mandating immediate emergency care. Crohn disease presents with abdominal pain, 84% of patients, diarrhea, 78%, and weight loss, 45%. Ileocecal involvement yields right lower quadrant tenderness in 62% and palpable mass in 15%. Extraintestinal manifestations, arthralgia, 30%, erythema nodosum, 12%, and uveitis, 8%, are documented. In pediatric Crohn disease, growth failure, height Z-score 2, occurs in 22% at diagnosis. Physical findings of abdominal tenderness have a sensitivity of 70% and specificity of 65% for active disease. Red flags include peritonitis, massive gastrointestinal bleeding, greater than 500 milliliters, and toxic megacolon, colonic diameter greater than or equal to 6 centimeters on CT. Diagnosis: 1. Spirometry. Pre-bronchodilator FEV less than 80% predicted and FEV/FVC less than 0.70. A greater than or equal to 12% and greater than or equal to 200 milliliters increase in FEV after 400 g albuterol confirms reversible obstruction. Sensitivity equals 88%. Specificity equals 76%. 2. Peak expiratory flow, PEF. Variability greater than or equal to 20% over 2 weeks supports diagnosis. PPV equals 84%. 3. Fractional exhaled nitric oxide, FeNO greater than 35 ppb indicates eosinophilic inflammation. Sensitivity equals 71%. 4. Allergy testing. Positive skin prick to perennial allergens in 45% of moderate asthma patients. 1. Endoscopy. Ileocolonoscopy revealing ulcerations greater than or equal to 5 mm, skip lesions, and cobblestoning. Diagnostic yield equals 92% when combined with biopsies. 2. Histology, transmural inflammation, granulomas in 30% of biopsies, specificity equals 99%. 3. Imaging, magnetic resonance enterography, MRE, shows bowel wall thickness greater than or equal to 3 mm and mesenteric fat stranding. Sensitivity equals 85%. Specificity equals 90% for active disease. 4. Laboratory, elevated C-reactive protein, CRP greater than 5 mg per liter, in 68% of active Crohn patients. Fecal calprotectin greater than 150 g/g predicts endoscopic activity with an AUC equals 0.88. Key points: asthma versus COPD, fixed obstruction, FEV/FVC less than 0.70, without reversibility suggests COPD. Alpha-antitrypsin deficiency prevalence equals 1.5% in early onset COPD. Crohn versus ulcerative colitis, continuous colonic involvement and crypt abscesses favor UC, perianal disease, present in 35% of Crohn, is a distinguishing feature. Bronchoscopy is reserved for atypical asthma with suspected airway remodeling. Biopsy shows subepithelial fibrosis in 12% of severe cases. Capsule endoscopy is indicated when MRE is inconclusive. Diagnostic yield equals 78% for small bowel lesions. Management and treatment. Asthma, inhaled budesonide. Crohn disease, oral budesonide. Key points: asthma exacerbation, administer nebulized albuterol 2.5 mg, 0.5 mg every 20 minutes for 3 doses, plus ipratropium 0.5 mg, and systemic prednisone 40 to 60 mg orally or 4-methylprednisolone 60 mg Q6H. Monitor SpO2, heart rate, and arterial blood gases. Aim for SpO2 greater than or equal to 94% and pH greater than or equal to 7.35. Crohn flare. Initiate 4-methylprednisolone 40 mg daily. Assess for perforation via CT abdomen. Free air detection sensitivity equals 95%. DOS. Budesonide 180 g per actuation. Low-dose regimen 200 to 400 g/day, 1 to 2 puffs bid. For mild persistent asthma, medium dose 400 to 800 g/day, 2 to 4 puffs bid. For moderate disease, GINA 2024. Route, pressurized metered dose inhaler, PMDI, with spacer, alternatively, dry powder inhaler, turbohaler, delivering 200 g per inhalation. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.